Do you or your child have a food allergy? Well, this episode is for you. Today, we're diving into the OUtMATCH trial, a study that looked at using Omalizumab, also known as Xolair, to see if it could increase the amount of allergen a person can eat. It's not a cure, but it might offer a safety net. We're going to break down how the study worked, what the results showed, and what it could mean for the future of food allergy care. This podcast is made in partnership with the Allergy and Asthma Network. We want to thank Genentech for sponsoring today's episode. While they support the show, all opinions are our own and sponsorship doesn't influence our content or editorial decisions. Any mentions of brands is for informational purposes only and not an endorsement. Now let's get to it. You're listening to The Itch, a podcast exploring all things allergy, asthma, and immunology. Welcome back to another episode of The Itch Review. Today we're talking about the article Omalizumab for the treatment of multiple food allergies. This was published in 2024, so it's a little bit older, and it was in the New England Journal of Medicine. This is really exciting, groundbreaking research because it's looking at this medication called Omalizumab for treating food allergies. So as you know, I have multiple food allergies. My interest is piqued. And we're talking about something called the OUtMATCH trial, right, Dr. G?
Yes, that's right, Courtney. Until now, we really haven't had any FDA-approved treatments for food allergy. So this was approved last year, of course, but we're reviewing the article now because it's always still relevant to understand exactly how a medication was approved. This research will go through the first large study that was done on Omalizumab, showing that it could help protect people against reactions from multiple foods at once.
Very exciting. So other than why it's important to me because I have multiple food allergies, how common are food allergies and why is this study such a big deal in the food allergy world?
So we know that up to 8% of children, 10% of the adult population, and many children, in fact, they're allergic to one food, have allergy to more than one food. So things like maybe peanut and milk or egg or tree nuts. There's lots of data showing this. Some US survey data that's been done show that anywhere to 30 to 40% of food allergic children are allergic to more than one food. And even the FDA has cited that, in fact, over a third of children with food allergy are allergic to more than one food. Managing these allergies is so difficult. You have the constant vigilance that the patient has to do, or if we're talking about the young children, the parents, avoiding things like birthday cake that may have allergens, or skipping certain restaurants, or worrying about any type of accidental exposures that can occur there. So we see this in these children. It really impacts their nutrition, a big problem with their social life, and can have real mental health problems for these children with food allergy.
Dr. Blaze, you spoke to my heart. Yes, food allergies definitely impact your day-to-day, even as an adult. And I can only imagine the fear that parents are going through when they're, sending their kids off to school and they can't control their environment. Because honestly, you can't put your kid in a bubble. And my parents couldn't do it. So I don't think parents in 2025 can do it either. So I can see why this is really exciting for both adults and kids.
Yes, exactly. And that's why this study was so important. It's not about curing food allergies, and I want to be really clear about that, but about making life safer and hopefully less stressful. So these patients, as we'll see, still have to actively avoid their food and carry around an epinephrine device. So this is not a cure, but it can help reduce those accidental exposure reactions that happen often for people with multiple food allergies.
Thank you, Dr. G. I think that was really important to just reiterate one more time that what we're going to be talking about is not a cure for food allergies. We're not there yet. So we're talking about Omalizumab, and I know that a lot of us know it as Xolair. So when you hear Omalizumab, you can also just think Xolair because that's the common name that us patients like to use because Omalizumab is a mouthful, let's be honest. And we have talked about this on our podcast in the past when we talk about asthma, and we've talked about it with hives, but how does that work?
So what omalizumab does, in an easy way to try to understand it, is basically it blocks IgE. And that's the antibody that in fact starts the allergic reaction when a child eats a food that they're allergic to. So by stopping this IgE from attaching to allergy cells that we have throughout our body, mast cells, basophils. It makes it less likely, in fact, for those cells to release chemicals, things like histamine, that in fact can cause symptoms like hives and swelling, itching, trouble breathing, all the way to, again, full-blown anaphylaxis.
Okay, so it's our friend IgE. I think we can't get an episode without saying IgE at the moment, so that's really interesting if you've listened to the podcast in the past. So what I'm hearing is that the Omalizumab is actually binding to the IgE, and the IgE is the reason we get all of these chemicals released, because the IgE normally binds the mast cell or the basophil, and then boom, you get your reaction. But in this case, it sounds like the IgE is being blocked from doing that. So it's not stopping everything, though, is it, Dr. G? Because you said it's not a cure, so I'm assuming it's not blocking every single IgE that's floating around in the body.
Exactly, Courtney. So as we mentioned, this is not a cure. When omalizumab was actually first approved, it was one of the first biologics, and it was approved for asthma. And because of the mechanism of action, a lot of allergists at that time were kind of curious. Will this be the cure? Will we just put all of our patients on omalizumab and then all of their allergic disease will be taken care of? And unfortunately, that wasn't the case. So it does bind some of the IgE and it does prevent some of these reactions and helps with asthma, urticaria, chronic sinusitis with nasal polyps. And so it's approved for many conditions, but it's not a cure. And with food allergy in particular, what it's doing is it's actually increasing the threshold for the amount of food that somebody can tolerate before they're going to have a reaction. So that specific term you'll hear when you're reading about omalizumab is threshold. What that means is that the baseline of what somebody can tolerate before they react is increased. So before, if somebody could not tolerate half of a peanut and they would react, well, after omalizumab, the goal is that they would be able to tolerate a whole peanut before they react. So again, they will still react to the food, but it'll just take more of the food in order to get that reaction.
It sounds like it's not going to cure it, but it's going to give you a lot of peace of mind. Like Dr. Blaze said, allergens can pop up in lots of places, like cross-contamination or may contain. And if your threshold increases, it just sounds like you feel a little bit less stressed when going out into the world. So I feel like that's probably for patients enough sometimes to just be like, I'm a little bit safer when I go out into the world. So now that we get an idea of why this is such an important medication, what was this study? What were they looking for, Dr. Blaze?
So this was a phase 3 randomized double-blind placebo-controlled trial. This is the highest, the gold standard as far as trials. And again, very important here for approval, which did occur by the FDA. So what they did here is the researchers screened people from the age all the way down to 1 up to 55 who had confirmed allergies to peanut plus at least 2 other foods. So foods like cashew and milk, egg, walnut, wheat, hazelnut. And for these patients to qualify for this particular study, they had to go through a series of skin and lab tests to confirm, again, that they had these sensitivities. And then to completely prove it, they had to do the gold standard, which is a double-blind, placebo-controlled oral food challenge. And these challenges involve gradually increasing doses of that allergenic food every 15 to 30 minutes. And how they determined eligibility here then was hinged on those patients having true strong allergic reactions to these particular foods. And this is what we call a dose-limiting symptoms, triggered by very small amounts of the food. So when we talk about peanut, they had to show symptomatology with 100 milligrams or less of peanut protein with about 144 milligrams of total consumption. And that is basically a little less than a half of a whole peanut. And then 300 milligrams or less of the other food allergens that they had, which again would equivalent to about 440 milligrams that would be totally consumed. And then they had to go through a placebo challenge with oat grain to make sure that they, again, would not react to a food that, again, they have no sensitivity to. And then the patients also were enrolled into this study needed to have a body weight and a serum IgE level that fit the omalizumab dosing guidelines. So they used the same guidelines that are used for asthma use of this particular drug. So very detailed as far as making sure that these were patients that had true significant sensitivity to these particular foods.
Wow. So it sounds like there are a lot of criteria for patients to even be considered with this study. And it sounds like the patients were prepared to commit a lot of time before even being considered to be a participant. Because I know I have personally done double-blind placebo trials, and they are a long process. And I think I'm just going to explain it a little bit for those who don't know. So basically what happens is you are eating your allergen or you're not eating your allergen. That's why it's double-blind. So you don't know, and the person who's giving it to you doesn't know. And that's because a lot of times I've had this experience where I think I'm eating an allergen. So I have a very psychological reaction to what I'm eating, but I'm not actually having a food allergy reaction. So that's why you want to do the double blind, so your brain isn't playing a role in the whole thing. And so what happens is you eat your allergen, and you first eat it in a little bit and then increasing doses, and they see if you react, right? So they start with a small amount and then you're okay, and then they'll give you a new amount and it's got a little bit more of the allergen until you react or you don't react. And it sounds like in this case, they're giving the patients very small amounts, and they want them to react to a very small amount before 100 milligrams. So that's what they're waiting for. They're waiting to see if they're going to react. And then Dr. Blaze mentioned 144 milligrams. And from what I've been explained in the past, basically in one sitting, the patient has eaten 144 milligrams, and that's like cumulative over the time. So you start with a small amount, and then, like I said, you eat more and more and more. And by the time you hit 100 milligrams, you've consumed a total of 144 milligrams of peanut, right? So it's not that you're eating 44 milligrams at the end in one dose, is that you've eaten throughout the whole time that 144 milligrams, just so you know what that means, because it can be very confusing, but that's what that number is saying. Now that we know what a double-blind placebo trial is, these patients had to do 4, right? Because they had to react to peanut, they had to react to 2 other food allergens, and then they had to do a challenge to oat to see if they weren't allergic. So that's a 4-day commitment that these patients are doing. So it's a lot. The one thing I didn't talk about really was that we talked about the amount of peanut they had to be eaten. They have to eat more of the other food allergens because Dr. Blaze mentioned they have to eat 300 milligrams. Dr. G, why didn't they have to eat 100 like with the peanuts?
So what this basically means is that they're not as sensitive to the other 2 foods. So when the researchers first set out to do the study, they wanted the most sensitive patients. I think they originally did set that criteria as 100 milligrams or less for all the foods. But then as they started to do the trial, they realized that people may be sensitive to peanut at that level where they can only consume up to 100 milligrams of peanut before reacting. But for the other 2 foods, they didn't want to have such strict criteria. So these patients were not as allergic to the other 2 foods. So they were able to consume up to 300 milligrams of that food allergen protein before reacting. So their threshold for that food was higher, meaning that they were able to eat more before they reacted. For those patients, again, 300 milligrams or less. And then if they had gotten up to that 300 milligrams, then total over the entire day, they would have consumed 444 milligrams of that particular food allergen protein. So those are the numbers that you'll see.
Okay, thank you very much. That makes sense now. And it's very interesting to hear. And then one other, I just wanted to clarify the last criteria, or the second criteria that Dr. Blaze mentioned, and that's the dosing of omalizumab. And from previous episodes, I can remember that it's dosed by weight and by IgE levels. So they wanted to check if obviously this patient fits the dosing criteria. Is that right, Dr. G? Does my memory serve me?
Yes, exactly. So we dose omalizumab in different ways, okay? And that's true for a lot of different medications, but for omalizumab in particular, we use that person's IgE level before starting treatment with omalizumab as a guide to how much of the medication we're going to give to them, and also their weight. So in this situation, what the researchers decided is that we're going to use the same dosing guidelines for asthma. They wanted to make sure that the weight and the IgE levels were in line with what the weight and IgE levels were for the asthma patients that can get omalizumab. And so the one issue with that is that a lot of people who have eczema will have food allergies, and a lot of eczema people will have higher IgE levels at baseline. And so a lot of people that would want to or would potentially need to get omalizumab may not qualify because their IgE levels are too high. And so that's also something that in the future researchers want to look at is what happens if the patient has higher IgE levels? Can we still use omalizumab in those patients?
Thank you for clarifying that. So, other than those two things, the amount of allergen you can eat or can't eat, and if you fit the dosing requirements, was there anything else they were looking for in the patients?
Yeah. The other thing that they wanted to look out for were people with poorly controlled or severe asthma. So those people were not included because when you have poorly controlled severe asthma, then if you were to have a reaction to your allergen, you would be at higher risk of a life threatening reaction, right? Where it would be more complicated to help treat you. And so we wanted to make sure that anyone in the study had asthma that was well controlled. Okay. The other thing that they looked for was a history of a life threatening anaphylactic reaction in the past that required intubation, or where somebody had neurologic complications. And what that means is that they had a reaction, and then from that reaction, they had injury to their brain, or they had to have a tube put down their throat in order to help them breathe because of that reaction. So if they had that kind of a life-threatening anaphylactic reaction, they were also excluded from the trial. Because they had to do so many food challenges, they wanted to make sure that the patient hadn't already had such a severe complication from their food allergy reaction. In addition, anyone who's been on prior food immunotherapy, so anyone who had done oral immunotherapy for their foods, would not be considered for the study, or anyone that was on a monoclonal antibody or a biologic medication for any other condition was not allowed to be considered for the trial.
Thank you. So it sounds like they really wanted to protect their patients when they were entering this trial, right? They wanted to make sure that you haven't had a very, very severe anaphylactic reaction because you're eating allergens and they don't want to take that risk. The same goes with asthma. They don't want to have that risk. And then the other things that you said, Dr. G, was they don't want patients who have done OIT or patients who have also been on a biologic because you've already kind of played around with your food allergies in the past, say, or at least your immune system with the biologic, and they don't want that. They want a clean slate. So they're looking for those patients. Once they did all of this work, who actually enrolled in the study?
Exactly. So this study was actually very cumbersome to participate in, but the participants were very motivated, as you mentioned, because they really wanted to participate in the study to help move research forward and to see if this would be helpful for their personal food allergies and for the greater good of everyone with food allergies. So it was a big undertaking for the parents and for the kids, but everyone participated even during the COVID pandemic. They continued to participate in the study. So it was pretty impressive. After all of that, they were able to enroll 177 children and adolescents from the ages of 1 to 17 years old with a peanut allergy, plus at least 2 other food allergies. As we mentioned, the cashew, milk, egg, walnut, wheat, or hazelnut. And a total of 56% of the participants were boys, and the median age of all the participants was 7 years old. And participants were highly atopic, which means that they did have other allergic conditions like asthma, atopic dermatitis, allergic rhinitis, and they either had one or all three were reported in a lot of patients. And I'll just mention really quick that there were some adult patients, but because there were so few, they didn't really put those patients into the data that was actually presented in the paper. So it just shows the information for those 177 children and adolescents between the ages of 1 to 17 years old.
There is nothing like a highly motivated food allergy parent, I'm just saying. So it sounds like then it was mostly a study for young people. And once they gathered all of these patients, what did they do?
These patients were randomized 2 to 1. So, what we mean by that is that 2/3 of the patients in this study got omalizumab injections, and a third got placebo. So, again, injections that, again, did not have any medication. And the treatment lasted for 16 to 20 weeks in this particular study.
So at this point in our podcast episode, we talk about the endpoints. What were the endpoints of this study, Dr. G?
Yeah, so there's something called a primary endpoint, which was really the main goal of the study. And then there's key secondary endpoints, which are also things that the researchers definitely wanted to look at. The question that they were asking was that after treatment, could the child eat at least 600 milligrams of protein, which is about 2.5 peanuts, without a moderate to severe allergic reaction? So they wanted the threshold to be increased all the way up from 100 milligrams or less to 600 milligrams of the protein. So the key secondary endpoints, other things that they wanted to look at, had the same idea, but with the other foods. But here, they wanted the patients to go from 300 milligrams of tolerating the food allergen protein all the way up to 1,000 milligrams before they would react. So they wanted the threshold to increase all the way up to 1,000 milligrams, which is about 1 to 4 teaspoons of those particular food allergen proteins. And again, those are those other foods that the patient would be allergic to. They also wanted to see, so the people that were able to tolerate the peanut, were they also able to tolerate both of their other foods? So all 3 foods, their threshold increased? Or was it that patients only had their peanut increase and the other 2 didn't increase? So they were looking at all the variations and wanted to understand, were all of the foods increased when the patients were on omalizumab, or was it preferential for one food over another? So those were other things that they were curious about and that they collected data for. Additional endpoints that they looked at were safety, and then they looked at quality of life measures also.
I feel like we set this up nicely, that obviously what they were looking for was to see if you could eat more of the allergen. And they wanted to see if you could eat all of the allergens and how much more. And then they also measured other things. And I think it's really interesting that they measured quality of life because, again, this isn't a cure, but it's giving you peace of mind, right? So that's a very interesting endpoint, I find. What were the results?
Yeah, so what they found was that for peanut, 67% of the kids on treatment with omalizumab could tolerate at least 600 milligrams of the protein versus just 7% for the placebo group. So there was a significant difference between the people on omalizumab where their threshold increased compared to the people that were not on omalizumab. And then for the egg group, 67% of the kids on omalizumab increased their threshold versus 0% in the group that was on the placebo medication. And then for milk, it was 66% versus 10%. And then for cashew, it was 41% of them increased their threshold compared to only 3% that were on the placebo. And for walnut, it was 64% compared to 13% that were on placebo. And then for hazelnut, it was 65% of patients increased their threshold compared to 14% that were not on omalizumab. And then for wheat, it was 75% of patients increased their threshold compared to only 13% that were on the placebo. And so all of the foods did show that omalizumab did make a difference in the threshold of the amount of food that the patients were able to tolerate.
That sounds like a very big difference for these patients.
When one looks at the data here, many of those patients were on omalizumab and tolerated a higher amount. Some of the patients in the study could tolerate equivalent to a full serving of the particular food that they were allergic to. And if we look at the placebo group, again, they reacted to very tiny amounts. But I do think it's important to understand there were patients that were receiving omalizumab that were unable to consume food protein without having moderate to severe dose limiting symptoms. Now, when one looks at the study, the researchers did observe a substantial variability in response. And again, as I mentioned here, some clear treatment failures. Now, you can explain some of these failures by the specific criteria that they used in the study for success. For example, a patient whose maximal tolerated dose, say, went from 3 milligrams to 300 milligrams would have substantial protection against a small accidental exposure, but in fact would not have met the endpoint criteria. However, 14% of patients could not consume 30 milligrams of peanut without dose limiting symptoms, which in this case would be considered as far as a treatment failure. So I think it's important to understand is not everyone got the protection from omalizumab that would prevent them from having a severe reaction with a small amount of the particular food.
Okay, so what I'm understanding is that you have the patients who got the protection and they met the number that the researchers were looking at, right? They met the 600 milligrams of peanut, say. And then there are some patients who, like, quote unquote, failed, but it's not that they technically failed, it's that they didn't meet the number that the researchers were looking for, but they were still able to eat or tolerate more of their allergen than they did at the beginning of the study. And then there's still a group of patients where they couldn't tolerate any more of their allergen than they had at the beginning of the study. Is that correct?
Yes. And I think that that is what makes patients a little bit insecure about starting omalizumab is that there was a group of patients that didn't really increase their threshold. Although it was a small group, there were still some patients that didn't respond. And what's true is that in real life, we're not going to be doing a baseline threshold. So we're not going to be challenging our patients before we start them on omalizumab like they did in the study to figure out what their baseline threshold is. We're not going to do that in a regular clinical office because it takes too much time and it's too dangerous, to be honest with you, in a normal clinical setting to be doing challenges like that. And so we're not going to be doing that. And then we're also not going to be doing challenges once the patient's on omalizumab. So the key thing to remember that I pointed out in the beginning and that we've mentioned a couple times here is that this is not meant to be a cure. It's just meant to increase your threshold. For most people, it does increase their threshold for one or two or all three of their foods, but for some people it didn't. And so the key thing to remember is that we are still practicing avoidance of the food while we're on omalizumab, and we're also still carrying our epinephrine device. If someone is on omalizumab, they have an accidental exposure and they still reacted and it was a trace exposure, for example, then that is really how we're going to figure out maybe the omalizumab didn't work for that particular patient. And then at that time, with shared decision making, we may pull the patient off of omalizumab. So these are real world decisions that you have to make with patients. And that's why shared decision making is so important, where some patients may respond, some patients may not respond. And with this medication, the key thing to remember is just that it is not a cure. That's really important for all patients to remember that.
So I think those are all extremely important points that we don't know when we do put that patient on omalizumab, how much protection they're going to have. We know that, again, it's a high percentage of the patients, but not everyone. And again, as Dr. G mentioned, they still need to practice avoidance. They still need to carry their epi device. And there were some other interesting findings that I think are important for the patient, and that was response rate when they looked at multiple food challenges. So what they did here, again, and what they were able to show was that about 71% of the omalizumab pediatric patients could in fact tolerate a total of 600 milligrams of two allergenic foods in a single dose versus only 5 with the placebo group. And 67% of the omalizumab pediatric patients could tolerate up to at least 1,000 milligrams of the two allergenic foods in a single dose, where it was only 4% with placebo. And then they also looked at children with 3 food allergens. And what in fact they showed here was that 48% of the omalizumab patients could tolerate a single dose of at least 600 milligrams of the three foods, where only 4% of the placebo could. And 39% of the omalizumab patients here could tolerate a single dose of at least 1,000 milligrams of the three foods, where none of the placebo patients could. So those are all also very reassuring results.
When you say single dose, Dr. Blaze, what do you mean by that?
So, what they were doing here is trying to see how many of the patients got a response to multiple foods. Because again, we had children here with allergy to peanut along with at least two other foods. So, what you have here is that they were able to show that they got protection. In fact, if we go back to the omalizumab patients, that 71% got protection or could tolerate at least 600 milligrams on separate challenges of each of those two allergenic foods. And then they also looked at children that had, again, three food allergens. And again, they were able to show that there was a high percentage of the omalizumab group that could, again, tolerate at least 600 milligrams or at least 1,000 milligrams of each of those particular foods. So showing that, I think the bottom line here is that many of these children got to be able to tolerate more than just the one food, but at least two or three foods that they were allergic to.
Okay, so they wanted to see if it worked on more than just the one allergen. So it wasn't just peanut. They wanted to see how many kids did it work for, where it was protecting them or increasing their threshold for multiple food allergens, correct?
Right. And that's one of the exciting things about this particular study is because now there is this treatment that can help protect for multiple food allergies with one treatment. And we've never had anything like that before.
As a multiple food allergy person, it's very exciting to hear. So what about quality of life? Because you mentioned that, Dr. G, in one of the endpoints that they were looking at.
Yeah, so they were looking at quality of life. And interestingly, during the blinded part of the study, the quality of life scores didn't really change much. And the thought behind that is probably because families didn't know if they were on the drug or placebo. So they stayed really cautious, right? So they were still really worried about accidental exposures. They didn't feel protected. They didn't feel any security that maybe they could go to the restaurant or they could go to a party without being as vigilant. But what they did find is that in the open label extension, which is where we haven't really talked about that, but there's something called the open label extension where the first 60 patients that finished the double blind placebo controlled phase of the study, because everyone was kind of on a different timeline because there were so many food challenges that needed to be done. It wasn't that every single one of those 177 patients was doing those challenges right at the same time. It was just too complicated to do that. So the first 60 patients that finished the original phase went on to what we call an open label extension. And an open label extension, it means that in this phase, everyone got the omalizumab and that both patients and researchers knew that they were on the medication and not on placebo. And while they were in that phase of the study, there were some improvements that they noted in the quality of life measures. And I also want to mention that there's also a second stage to this study, and that will compare longer term 52 weeks of treatment with omalizumab. And they're also going to add oral immunotherapy for multiple foods. And then the third stage will assess the introduction of allergenic foods into the diet for ongoing consumption. And that's going to be a minimum of 52 weeks. And that's at home after they've actually come off of the omalizumab treatment and oral immunotherapy. So essentially, it's just looking at if there was sustained effects from the omalizumab therapy and if the patient is then able to tolerate continuing to eat their food allergen.
Thank you for explaining the open label extension portion of this, because it makes sense to me now that quality of life didn't necessarily increase while they were in the placebo trial because they didn't know if they were on the omalizumab. And I think that as a food allergy parent or as a food allergy person, you are hypervigilant in life. And until someone makes you feel like you don't have to be always on guard, you're going to be on guard. So that makes a lot of sense to me. Talking about hypervigilant and always keeping safety at top of mind as someone with food allergies, what about the safety in this study?
So what was seen here is the side effects were really very mild in this study. The most common thing we see this with all the different biologics, is injection site reactions were more common in the omalizumab group. Now, there was one child that had elevated liver enzymes during the study, but the investigators did not believe this was related to the medication. And very importantly here, there were no cases of anaphylaxis caused by omalizumab in the study.
That's very cool to hear, because I always think of omalizumab and one of the side effects is anaphylaxis. And I always wondered, I was like, if we're using omalizumab for food allergy and we're trying to prevent anaphylaxis, yet the side effect is anaphylaxis, there was just a lot of like, okay, that's kind of weird. And that's a discussion that happens a lot in the food allergy groups online. So that's exciting to hear that actually no patient in this study had anaphylaxis from omalizumab. So that's very reassuring, since you're taking it for preventing anaphylaxis really at the end of the day. So it sounds like everything is quite positive.
Yeah, and it's consistent with what we've seen in asthma and our patients with chronic spontaneous urticaria over the last 20 years of use as far as the safety profile. And yes, Courtney, the whole anaphylaxis with omalizumab is a very, very rare complication. And again, as you can see in this study, they didn't show any anaphylaxis related to omalizumab at all.
Well, thank you so much, Dr. G and Dr. Blaze. This is really exciting for the food allergy community. I know that when this came out a year ago, there was a lot of buzz. I would love to end the episode with your big takeaways. Dr. Blaze, let's start with you.
So we look at here, I think it's very important to realize that this is a very valuable treatment for food allergy, especially multiple food allergies, where doing oral immunotherapy is really not practical for most of these patients. I do think we need to have much more data on long-term durability. We need adult data in those patients that are suffering with multiple food allergies. And I think it's also important to realize again that this is not a cure, that patients still need to carry their epinephrine. They still need to be vigilant as far as watching for exposure to particular food allergens. And we also need to remember and let our patients know that there are still a small number of patients that did not get significant protection from accidental ingestion with omalizumab.
Yeah, for me, omalizumab did significantly increase the amount of food allergens people could tolerate. And I think that's really important to remember. And as Michael mentioned, that it's to multiple food allergens. And those are really the patients that I think will benefit the most. But again, it's a shared decision-making conversation, talking about the pros and cons of being on this medication and what kind of security it would provide for the person and the family. And this medication, again, is approved, even though most of the data is on kids, it is approved for adults too. So, hopefully with more use and with more real life patient data, we'll understand exactly where omalizumab fits in for the majority of patients with food allergies.
Thank you so much again, Dr. G and Dr. Blaze. I really hope this episode helps a lot of patients and practitioners. I know there's a lot of question marks, and as you mentioned, a lot of patients aren't sure whether it's something they want or not in their lives. And I hope that this gives them a little bit more information they can go to their doctor with and have a shared decision conversation.
Thank you for listening to today's episode. Remember that all information you hear today is for informational purposes only and are not intended to serve as a substitute for the consultation, diagnosis, and/or medical treatment of a qualified physician or healthcare provider. And also, don't forget to subscribe to our podcast. And if you have a second, help spread the word by rating our podcast and sharing with your friends and family who might also be interested in learning more about allergies, asthma, and immunology. You can always stay up to date by checking out our Instagram, The Itch Podcast, where you can leave questions you are itching to know, or check out our website, which is www.itchpodcast.com, which contains more information about the subjects we covered in today's episode and every episode. Until next time, have a fabulous week.